Today we learn about the common gastrointestinal symptoms in palliative care. Okay, so let's start with the alimentary canal, the gastrointestinal system, which starts with the stomach and ends in the anus. We come across a lot of common gastrointestinal problems. The common ones are oral thrush, starting from the mouth, which starts with the oral thrush, stomatitis, dry mouth, nausea, vomiting, and coming down to constipation, diarrhea, and intestinal obstruction. Today, we'll be stressing more on nausea and vomiting. So, what is emesis? Emesis is a forceful expulsion of the stomach contents. So, is it a good thing or bad thing? Yeah, it's a good thing. No, it's a biological defense mechanism. Like all other organisms, I have shown a picture of a chameleon who has the ability to change its color to protect itself from an enemy. Our body is also made in such a way that we can remove the toxic substance or harmful substance from our body if we have accidentally ingested it. We'll at least feel a nauseated feeling so that we'll not take it anymore. That is, that's how it becomes a biological defense mechanism. So I think everyone in this group have at least once in their lifetime that they have experienced a nausea and vomiting. So there are three phases of emesis. Just remember or recollect an episode of vomiting you had. First, we'll have a nausea. What is nausea? Nausea is an unpleasant sensation and an imminent need to vomit. So it's an unpleasant sensation. Mostly it will be the patient will feel like there is something in the throat or there is some problem in the stomach. And sometimes this nausea will be preceded by vomiting, or sometimes the patient will keep on having nausea alone. Okay. The nausea is followed by retching. What is retching? Retching is a spasmodic contraction of the diaphragm. First, you feel a nausea, then the abdomen and all the muscles will contract, the diaphragm will contract, and it will expel the gastric content. This may also, like sometimes, result in vomiting, or sometimes the patient will keep on having retching. There is also one more thing that these diaphragm and abdominal muscles are closed against, contracting against a closed glottis. That is also a protective mechanism to protect, to prevent aspiration. Otherwise, this food, when the stomach expels the food, the contents will go to lungs. So to prevent that, the glottis will be closed. So what we feel like everything is coming out and we feel a choke sensation. That is called as retching. And finally, vomiting. What is vomiting? It is a forceful expulsion of the gastric contents. So there is one more thing. You have to know about all these terms. That's why I'm explaining it. And what about regurgitation? Regurgitation is something like the babies have. The food is brought back to mouth without any contraction of muscle. The patient will not have any pain or anything, but they'll tell like that the food they have taken like a little before will come back. So, already we have discussed it is an unpleasant sensation. Either it is felt in the back or in the throat or in the stomach, and it usually proceeds vomiting, but may not resulting in vomiting always. So now we can classify this vomiting into different types according to the time of vomiting. So in palliative care, in our setting, where do we see see vomiting very commonly? Mostly, very commonly, we see with the chemotherapy. So we can explain it like that. Those patients. So the different classifications are acute, delayed, breakthrough, refractory, and anticipatory. Listen carefully. You have to know about all these terms very clearly. Okay. So the acute is if a patient takes a chemotherapeutic drug and the vomiting occurs very fast. As soon as he takes it, he will develop a vomiting. Occurs within few minutes to hours, and it resolves after within 24 hours or something. Delayed vomiting is what which occurs usually after 24 hours of chemo. And this patient will develop vomiting after, like, it will become worst after 40 to 72 hours and following a chemo, and it may last up to 6 or 7 days. These type of vomiting is always a nightmare for the patient. Now, so I think you have noticed in oncology department, most of the time, After chemo, the doctors will prescribe some anti-emetic drugs for at least 3 or 4 days to prevent vomiting. No? So even after that, some patients will develop 2 or 3 episodes or occasional vomiting. That is called as breakthrough vomiting. So what is the definition? Those vomiting which occurs despite antiemetic treatment. Okay, that is breakthrough vomiting. Now coming to refractory vomiting. Refractory means you give everything, you give all the medicines, you try everything, but still the patient is having continuous vomiting. That is called as refractory. And anticipatory vomiting. Can anyone tell what is anticipatory vomiting? Can anyone unmute and say what is anticipatory vomiting? Have anyone heard about it? Any clue about it? Just a wild guess. Anyone can give. No problem. If it is wrong, also no problem. Nobody knows. Okay, no problem. Okay, this is a new term. I think it will be new for you also. This is something which is not common. I'll give you an example. I'll give you an example of a patient.
Excuse ma'am.
Yes.
The nausea vomiting may occur before the chemotherapy treatment section, ma'am.
Yes, that's it. Yes, that's it. That is not very common. That is nobody, like most of the people don't know about it. Very good. Who has answered it?
Rajarajeshwari, ma'am.
Very good, very good. Okay.
Thank you, ma'am.
Okay, so that is anticipatory vomiting. That is, I'll explain it. If one patient is having chemo on Thursday, but he starts having developing like vomiting on Tuesday. Family is surprised. Why you are having vomiting like 2 days before? We are going to get chemo only after 2 days. What is this? People will ask, right? That is known as anticipatory. Patient will become anxious, and due to that, he can develop vomiting. So you need to tell. If someone is coming and asking or telling like this, he's developing vomiting 2 days before the chemo. You should know about this. There is something called as anticipatory vomiting. Okay. So the definition is a conditioned response prior to chemotherapy. Now, coming to, we'll quickly go through this different causes of vomiting. So, first one is a chemically induced nausea, different drugs. Tell me few drugs, which very common drug which causes this thing, nausea and vomiting. Can anyone tell? Very common.
Morphine.
Yeah, very good.
Tramadol, ma'am.
Yeah, very good. Very good. Very good. Okay. Opioids, antibiotics, NSAIDs, cytotoxic toxins, food poisoning. We get food poisoning and we vomit. So all these are included in chemically induced nausea. Then the next one is gastric stasis. There is no bowel movement. So that can be caused by anticholinergic drugs or opioids or morphine, ascites, peptic ulcer, and gastritis. All you can just read stretch or distortion of GI tract, which consists of constipation, which is very important, intestinal obstruction, mesenteric metastasis, serosal irritation containing liver mets and ureteric obstruction. Then very important one is raised intracranial pressure in the brain due to space SOLS, space occupying lesion, IC bleed, infection, cerebral edema. All these can cause this thing. And finally, the anxiety induced one, the anticipatory vomiting, anxiety induced vomiting. Okay. So how will it affect? How is it going to affect the patient? If you are like having continuous vomiting, you will the daily functioning is affected. The patient will have a poor quality of life. And what happens next is he'll think that this chemo is going to cause vomiting for me, so I am not going to take it. Next chemo, I am not going to take it. For those people who are having a treatable or curable type of malignancy, who is advised chemotherapy for 4 weeks, he'll stop within 2 weeks. So there will not be any complaints to cancer treatment. Also, there will not be complaints to analgesics. This is very common. Patients stop taking analgesics due to this nausea and vomiting. They'll take the poor fluid and oral intake. That is also very common in Indian culture. We feel very sad when our loved ones is not taking food, right? Most of the caregivers will tell like he's having vomiting, he's not able to eat anything. So how can I eat? And there will be caregiver fatigue. Family will be also in distress. Patient will be also in distress. They'll keep on vomiting. The family members have to take it. Everything will affect the quality of life. So this is how it is affected. So our goal as a palliative care nurse or a palliative care doctor, what we are trying to do is we have to try stopping or at least reduce the symptom of frequency. And there how we have to establish the compliance to treatment that and enable the analgesic medication and improve the quality of life. That is our goal. Okay. So we need to know that. One thing we need to know that, like before learning all these things, I'm telling my experience. When I used to think of vomiting, I have only one drug in my mind, and that was ondansetron or Emised, which we commonly use. But and also one more thing, if a patient with cancer or any advanced disease, when they are telling that I have nausea, vomiting, we used to think that what this is very common, that is associated with the disease. Is it like that? No, 40 to 70 percentage of patients with cancer and other diseases have nausea and vomiting. But if there is an accurate assessment, there will be a good symptom control. There are a lot of things causing vomiting. So today we are going to learn about it. And for each cause, there is a different management, a little bit different management. So for understanding this different type, we need to learn. Our brain should know. Okay. So our principle, in all other topic also we learn, like first we have to do is correct the correctable. Do whatever we can. For example, if the patient is having pain or the patient is having infection, something like that, we have to try to correct it first. And then we'll go for non-pharmacological measures. Non-pharmacological measures include avoiding the situation. Sometimes the smell, sight, all those things can trigger the patient. We have to give a calm, reassuring environment for the patient. We have to give fresh air, nurse in the upright position, control of malodor. Like I said already, some patients will be having colostomy, fungating tumor or decubitus ulcer. Because of the smell, they won't be able to eat. They may have nausea. So we have to address all these things first. But not a patient who is continuously vomiting, we are going to do this and all. It is not like that. All these should be kept in mind and we should address all these things also. And also dietary modification. This is very important. Patient's family will be very concerned. The patient is he's not taking any food. They'll try to force him. They'll ask them to eat very frequently and in large quantities. What we have to teach them? We have to teach them to take frequent small meals. Both words are important. Frequent small meals. And avoid fatty, sweets, more spicy and carbonated drinks. Eat only what is like a digestible, plain foods. Okay? And never force them. A patient having nausea, and if you try to force them to eat, he will definitely vomit. Nothing else is going to happen. So always counsel the family regarding this. The patient might have this, and once the nausea and vomiting comes down, he will improve his oral intake. Till then, don't force him. Okay. So now coming to pharmacological management, we are coming closer to the causes and drugs and all. So listen carefully. Okay. So our vomiting happens. When we vomit, a lot of things happen. All our activities are controlled by brain. So vomiting is also controlled by brain, and there is a point in the brain and it is called as a vomiting center. It is located in medulla of the brain. This vomiting center have a speciality. That is, it will not act by itself. It need a push, like us. We all need a push to go forward. Like that, for vomiting center to act, they need a push. They need different stimuli. So look at this picture. I have shown few points, which is very important. And okay. The vomiting center is stimulated by, in gross, I have divided into four. First First one is the GI, gastrointestinal system. Next one is the cortex of the brain. Next one is the chemoreceptor trigger zone, CTZ, and the vestibular system. Did you see that? We have to study about a few receptors. You have to have a little idea about the receptors because the receptors play a major role in here. Okay? So look at here. We have a GI tract and we have few receptors. I'll go to the previous slide. I'll go to the previous slide. Look here. We have a lot of neurotransmitters and their receptors. Please learn it. Okay. Cholinergic, it is represented as M1 and the small r is that is the receptor. Dopamine is a neurotransmitter and the receptor is D2R. Histamine is H1 like that. H1R and substance fee is NK1. Serotonin and the receptor is 3HT3 receptor. And opioid have mu receptors. Now come to this slide. See, in GI tract, we have few receptors. 5-HT3 is, you have to by heart it, okay. 5-HT3 is serotonin receptor. D2 is dopamine and NK1 is neurokinase. All these are present in the GI tract. We'll come to this later. Just have this picture in your mind. So from GI tract, the impulses are sent to vomiting center and patient will vomit. How? I'll tell later. And from the same like in cortex, they will send the impulse to the vomiting center and the patient vomit. Next, the CT said there are so many receptors D2, 5-HT3. Oh, CT said have a lot of receptors. Okay, that is why it is known as a zone, chemoreceptor trigger zone. D2, 5-HT3, HT3, opioid and neurokinin. See the vestibular system. There also we have two small receptors, M1 and H1. What was M1? It was acetylcholine, cholinergic, muscarinic, M1. And H1 is represented as histamine. So now let's learn how this acts. It's very interesting if you learn this. It will be very useful also. As nurses, like you will like patient and the caregivers will ask so many doubts to you also. So you should be knowing how it is causing and why it is causing. You should know a little bit. Okay. So coming to the first one. Okay. So we are starting with the GI. Okay. So what happens? Why does a patient receiving chemotherapy develops vomiting? That's what we are studying. Chemotherapy and radiation induced nausea. So what happens is when a patient receives a chemo radiation, it induces the release of serotonin from the gut wall, from the alimentary canal. Got it? When a patient takes chemo radiotherapy, there will be release of serotonin from the gut wall. That's what I showed the GI, first one. And what this serotonin will do, this serotonin will stimulate the CTZ. CTZ is very, it is a very important receptor. So trigger zone CTZ, and so the serotonin stimulates the CTZ, and the CTZ in turn stimulates the vomiting center and results in vomiting. See the previous picture. Look, from the GI, the vomiting center is stimulated. We have serotonin receptors there. Also, we have serotonin, the 5-HT3 receptors in the CTZ. That will also get stimulated and the patient gets vomiting. The vomiting center is stimulated. Okay, this is how a patient with chemotherapy develops nausea vomiting. All clear? Any doubts? Okay. Next one is, so why we are learning this? I forgot to tell about this. So the serotonin is causing the problem here, right? While patient is taking chemotherapy, the patient gut wall produces serotonin and the serotonin stimulate the CTZ. CTZ stimulate the vomiting center and the patient vomit. What we can do here? We can block the serotonin. So we have cetrons. Serotonin receptor blocker. That is our ondansetron. Got it? That's why in patients with chemotherapy and radiotherapy, we give ondansetron. The common brand name is Emiset, what we give. Okay? The next one. Have you ever wondered, like the post-operative nausea and vomiting, how does it happen? There also it is the same. In patients who are receiving, undergoing surgery, while the surgery is happening, the anesthetist will inject so many opioids to reduce pain for sedation and all. There, the administration of opioid, while we administer opioid, it stimulates the D2 receptor in CT cell. Okay, again I'll show the picture. I'll go back. I'll go back. See the picture once again. The D2 receptor is here in the CT set. The CT set, we have the 5-HT3 and D2 receptor. So the D2 receptors are stimulated in the CT set and it in turn stimulates the vomiting center and results in vomiting. So D2 is what? Dopamine. So in post-operative cases, what we can do to prevent vomiting? We can give something which is against dopamine. So we give D2 receptor blocker. That is our metoclopramide. Have you seen doctors prescribing Perinom or tablet metoclopramide before the surgery, after the surgery? This is the reason. Okay, when we administer opioids that act on the both mu receptors and on the D2 receptor, it will trigger the CT set and it will stimulate the vomiting center and patient will have vomiting. Now coming to the vestibular apparatus, simple one. The motion sickness. While we are traveling, we get a motion sickness. It's very common, right? There, what happened? There, histamine and acetylcholine will be released. And look at the picture back. In the vestibular system, we have, see, M1 and H1. That is acetylcholine and histamine. So, what we have to do? We have to block something. Antihistamines. We use antihistamines. Promethazine, common one. Avomine, we use very commonly, right? So, this is how it works. Now, from the cerebral cortex, the fourth one, from the cerebral cortex, some patients, even us, we get nauseated while seeing a bad, when we get a bad smell or a bad taste or a sight or memory of a bad or a fecal matter, a vomitus. How does we get a vomiting? It is because of our cerebral cortex. On the previous slide, see the cortex that is also stimulating the vomiting center. Cortex remembers all the bad smell, all the bad sight, all those things, and it will in turn trigger the vomiting center. So, in short, I was trying to tell that all these things, all these receptors are stimulating the vomiting center and thereby causing vomiting. Okay, all clear? So, we'll move forward. We'll understand it little more when we go forward. So that is how, see, our anticipatory vomiting, that comes under here. The cerebral cortex remembers about the chemotherapy and it will become anxious. So that is how the vomiting center is stimulated and patient will have vomiting. So in you see, no, all these cases, the medications are different. Different receptors are acting and different. We have to give different blocking or different medicines for different types. So in anticipatory vomiting, the patient is becoming very anxious. So what we give here is we give benzodiazepines to calm the patient. What if we are not thinking about this? A patient is having anticipatory vomiting, and if he's telling vomiting, you are giving Emised. Will it work? No. For that, you have to understand why the patient is developing this and how it is happening. What receptor? If you are giving you have to give proper medication. So in short, I'm telling it once again. In short, the chemotherapy, anesthesia drugs, the opioid drugs, all these will act on the chemoreceptor trigger zone and this will cause vomiting. In the chemoreceptor trigger zone, there are so many receptors, dopamine receptor, 5-HT3, opioid, neurokinin. So wherever These neurotransmitters are released whenever these neurotransmitters are released, these will get triggered and they will in turn cause vomiting. Now the same thing, bad smell, bad sight, thought of chemo, everything. In the cortex, the fear and anticipation, from the cortex, the vomiting center stimulated. There what we have to give benzodiazepines for anticipatory vomiting. Again, in chemotherapy, what happens? I've already told in chemotherapy, in the gut wall, serotonin will be released from the small intestine and it will affect the CT set and the vomiting center is uh, stimulated and patient will vomit. So just few examples of these receptors and the drugs. So acetylcholine receptor blocker examples. Okay, just go through it. Hyoscine and dicyclomine. First one, acetylcholine receptor blocker is hyoscine and dicyclomine. Antihistamine examples promethazine, what I've told, avomine, which is very commonly used. Dopamine receptors examples are metoclopramide. You should not forget this. Okay, metoclopramide is a D2 blocker. Serotonin 5-HT3. Cetrons, example is ondansetron. And neuroleptics, haloperidol, chlorpromazine. Substance P, aprepitant is rolapitant is, they are newer drugs. Okay, so this is a uh, no need to stress more on this. We have discussed already this. You will get confused. I've already discussed about this. Now, how do we give drugs? We give drugs according to patient's condition and preference. Sometimes the patient will tell doctor, I don't want injections. I need only tablets. And then will you tell like, no, you have to take this thing. You have to take injection only. No, it's not like that. Oral route is the best and easiest. But if the patient is having continuous vomiting, is not able to tolerate anything orally, uh, excuse me, sorry. Okay. So if the patient is having severe or continuous vomiting, you can give to parenteral route. Otherwise, you have to consider the patient's preference. If he is telling that I'm comfortable with oral, you also have to be comfortable. Okay. Then we have a lot of suppositories available, sublingual and transdermal patches, which is not very commonly used here. The most best and the easiest route is the oral route. So the treatment. So now you understood, no? The treatment should be
स्कूल
mechanism.
जाने म्हणते क्या
Okay. The treatment should not be generalized. You can't give for all kinds of vomiting. You can't give one tablet. It's not like that. Understand the mechanism, and it is not a generalized. Okay. So can you tell? We have already told, right? No. Okay. Drugs causing nausea and vomiting. The most common drugs. It will be. Any guess? Any guess? Very common drug which causes gastritis. Should come up in one, not even in seconds. Which drug causes gastritis?
Paracetamol.
Paracetamol can cause something more.
Brufen.
Yeah,
Brufen.
Brufen. Yeah, it comes under NSAIDs. NSAIDs.
Diclofenac.
Yeah, it comes under NSAID. Brufen, diclofenac, all comes under NSAIDs. All
Antibiotic.
antibiotic. Very good. Very good. Very common. So all these very good, all of you. You all
Some
are
antidepressant drugs are also to causing for the vomiting nausea.
okay. Fine. Thank you. So we should not focus all along this chemo drugs and all. We should see that the patient is having pain. Sometimes they'll be taking this. You will not be knowing, and you will prescribe Emisat everything and not. If the patient is taking NSAIDs, they should definitely take a PPI, right? Sometimes they won't be taking, and they'll present with gastritis. So you should think in all ways. Okay. So one more thing that is there is in we were telling about all chemo patients and all. Have you ever thought of the end of life patients who's all there is renal failure, hepatic failure. In renal failure, the level of urea rises and there is uremia. Hepatic failure, patients with ketoacidosis, hypercalcemia, all these toxins, all these also causes vomiting. Okay, In end of life, you'll be thinking in end of life, patients not taking, sometimes not taking morphine and no other problems. You're not able to identify the cause of vomiting. This is there. This is known as a biochemical causes. This comes under biochemical causes. These all things directly stimulate our CT cell. Okay. So this have to be kept in mind. All these can also cause vomiting. So then the next one, raised ICP, intracranial pressure, patients having primary or secondary brain tumors. In such case, can we give Emiset? Yeah, we can give, but we have to think about the cause. The tumor there is causing, it's a space occupying lesion. We have to reduce the peritumor edema. Then we can give a steroid, which is more helpful. That is the cause. We can at least reduce the peritumor edema. And also a radiotherapy can help, not our antiemetics alone. So we should think of this also. Okay. So few principles that we should always anticipate while starting. I think you have already learned about pain management, right? Yes. So we have learned that while we prescribe morphine, we always have to anticipate the patient might have a vomiting. So anticipate the need while starting morphine. This is very important. You should not forget it. Also, so I'll teach you how to start the this thing. And also one thing you should have to remember, you have to use a adequate and regular dose. You cannot use a underdose. And you cannot tell like you take it when you get one or two episodes of vomiting. No need to take regularly. Is that right? No, we have to give it regularly and in the adequate dose. Okay? And we have to think about a receptor, which receptor involved. At least you should have a little idea about which receptor you have. You can try at least. You can think. Hmm? For thinking, you need knowledge. You need to know something. Okay. And one another important thing is sometimes we may need a combination. One drug may not help alone. Sometimes we need to have two drugs that I'll discuss in coming this thing. And always anticipate an alternative route also. If we are like if the patient is taking only orally, taking orally means not able to continue orally, we have to think about another route also. Okay, it's not like patient told oral, so only oral. Nothing like that. We have to anticipate. Okay, so coming to the antiemetic drug classification, so we'll be learning about the very important things only we'll deal with. Okay, dopamine antagonist is D2. Just remember this thing. Antihistamine is H1, anticholinergic ACHM1, serotonin antagonist. So first one is metoclopramide. Metoclopramide is such a nice drug because it acts by three mechanisms. How does it act? It acts in three mechanisms. Okay. It acts as a D2 antagonist. Okay. It acts as a 5-HT3 antagonist. And cholinomimetic. It acts as a prokinetic. D2 antagonist means what? It blocks dopamine receptor. 5-HT3 antagonism means what? It blocks serotonin. Okay. Both by blocking these two, we can reduce vomiting. And it acts as a cholinomimetic agent. It acts as a prokinetic. What is a prokinetic? Prokinetic helps in inducing peristalsis. It helps in the movement of the alimentary canal. So the food passes very fast and the patient will get a empty stomach. Okay, it will push the gut forward. It prevents the gastric stasis. So how do we start metoclopramide? We can start with 10 milligram TDS. So whenever you start morphine, you have to prescribe this metoclopramide. It will be good if you are anticipating vomiting. Okay, you can start with a dose of 10 milligram TDS prophylactically. So the dose can go up to from 30 to 120 milligrams per day, and it acts for a duration of 6 hours. So one thing you have to remember here is in higher doses, metoclopramide have a side effect of extrapyramidal symptom. So you should be knowing about this point about metoclopramide. You'll get MCQs like which among the drugs does not have extrapyramidal symptom. We'll always think metoclopramide is an antiemetic. It won't be having any extrapyramidal symptom, but it is not. You have to think about this. in higher doses. I'm telling in higher doses. Okay. In higher doses, you have to be careful because it can cause extrapyramidal symptoms. So, metoclopramide as such is a very good drug because it acts in three ways. Okay. We always like multitaskers, right? Now coming to haloperidol. Haloperidol is also a wonder drug. Most of the people will be thinking, "Hey, this is an antipsychotic drug, right?" Your friend nurses who doesn't know about this will ask, hey, how can you write this antipsychotic drug for vomiting? You should know about it. You know, it is a D2 blocker. Haloperidol have a D2 blocker effect and that is in the CT set. It causes vomiting. Nobody knows about it. So you have to tell them, you have to teach them. Hmm? So one more thing is haloperidol is a drug of choice for morphine-induced vomiting or it is a drug of choice for opioid-induced vomiting. Okay, why? Because it directly acts on CT set. This haloperidol. See everyone here, listen. This haloperidol can directly act on the CT set. Okay, that's why it is very helpful. Also, one more thing we have already said. See that point. Chemical causes like uremia, renal failure, hepatic failure, acidosis, toxins. All these affect where? Where does it affect? It affects on the CT cell. So we can block it there. Haloperidol when act on can directly act on the CT cell and reduce the nausea vomiting. So how will you give haloperidol for opioid induced morphine means generally opioid. Okay. The dose we can give is 1.5 milligrams to 5 milligrams per day. Usually what we do is when we start morphine, we give metoclopramide. But if the patient, while continuing after this, we are continuing morphine for few days, then also patient is still having a severe vomiting, then we can try haloperidol. How can we give? We can give 1.5 milligram HS dose as a single dose or for 2 days. Okay. And also haloperidol can be used as oral, subcutaneous and by IV. So we learned about two important drugs, right? Metoclopramide and haloperidol, very common drugs. Now, document the likely causes. Okay, we are treating a patient with vomiting and we have to document it. What are the causes? Is it because of gastric stasis? Sometimes will not be able to achieve this thing very soon. Might be we have to change the antiemetic and see. For that, you have to document the likely causes. Is it because of the gastric stasis? Is it because of the intestinal obstruction? Is it because of biochemical causes, drugs, raised ICP? We have to rule out that, and also rule out other causes. Like I said, the correctable measures. If the patient is having severe pain and you are not looking onto it and you are simply treating vomiting, will it subside? Will everything subside? No. You have to look on to severe pain. You have to rule out infection. If the patient is having continuous cough, he is keep on coughing and finally he will vomit. Is it because any of the receptors? No. That is because of the cough and it is causing the vagal action to cause vomiting, hypercalcemia, anxiety, constipation. Constipation is another important factor we have to rule out. Patients having constipation will have loss of appetite, nausea, and vomiting. Sometimes this constipation could be because of intestinal obstruction, which we will be dealing in the next session. And so this is also very important. All these things you have to keep in mind. So, in short, how will we prescribe the most appropriate one based on receptor? Right, a patient is coming to your OP and you are writing a dose and giving, tell you go home and take this. Is it right? No, you have to give a stat dose. You have to manage in that time and then you have to give them regular dose and then you have to advise them to take a SOS dose also. Choose parenteral route if there is patient is having continuous nausea and vomiting. Okay. And also this is also very important. A single antiemetic may not be adequate in most of the cases. In 1/3 of the patients, one antiemetic might not be enough. For example, a patient with raised ICP and uremia. Okay, a patient having raised ICP and uremia. We need two things. What all we need? Uremia, we know where will it affect? It will affect the CT cell, right? Uremia, hepatic failure, everything will affect the brain directly on the CT cell. And for raised ICP, what can we give? We can give dexamethasone to reduce the inflammation, also to reduce the peritumor edema. So we can give a combination like this, dexamethasone plus haloperidol. So in short, I'm just making it short for you to understand. So most of the time for drug-induced nausea, vomiting, haloperidol will be the choice. Can be given at the dose of 1.5 to 2.5 milligram HS or SBD. For patients receiving radiotherapy, we know that the serotonin will be causing. So we'll give Cetron, anti-serotonin. So ondansetron can be given. That is our emiset. Ondansetron 8 mg stat and then 4 mg TDS. For chemotherapy, you can give both dexamethasone to reduce the inflammation and ondansetron 8 mg stat and then 4 mg TDS. Next, for metabolic causes, all the metabolic causes we listed, renal failure, hepatic failure, toxins, acidosis, all those can act on the CT set. And which drug directly acts on the CT set? Which drug directly acts on the CT set? Nobody knows.
Metoclopramide.
Haloperidol. Haloperidol directly acts on the CT cell. Okay. So for metabolic causes also, that is what I said in end of life patients who are having vomiting, continuous vomiting, we can give haloperidol. Okay. For raised ICP, what we give? Dexamethasone. Okay. 8 mg to 36 milligram IV. Delayed gastric empty, those patients who are taking morphine and all. One of the side effect of morphine is gastric stasis, right? So some patients we can give more metoclopramide 10 mg. You can give up to Q6 early. Okay. Patients with gastric irritation, like we said before, we can give. It's not PI, sorry, it's PPI. PPI and stop the irritants. So the opioid, I'm just briefing what I've said before. Opioid induced vomiting. I'm stressing more because you will have to come across this very commonly. So you have to remember this. Okay. How this opioid is causing vomiting? Because it acts by different mechanism. Opioid also acts on the CTS. It acts on the vestibular system. It causes constipation and stasis. So the drug of choice is metoclopramide or haloperidol. We usually anticipate and start metoclopramide when morphine is started. If it is not settling, we can try haloperidol also. Okay. Then yeah, we have to prevent with initial antiemetics. When we start opioids, start with antiemetic, and we start by giving tablet metoclopramide 10 milligram TDS and SOS. 10 milligram TDS for 2 days or 3 days we can give. Okay. So the anxiety-induced one, how will we treat? We told benzodiazepine. Which benzodiazepine we use? We can use lorazepam. Lorazepam is long-acting. You can remember by remembering L and L. Lorazepam is long-acting. Okay. Lorazepam, what is the dose of lorazepam? We can give either 0.5 milligram or 1 milligram. Okay. Clonazepam, which is short-acting. It is also benzodiazepine. We can start with 0.25 and we can hike up to 0.5 milligram HS. So at the end, we have to review the patient after 24 hours, not like giving the medicines and we'll send them, now everything is enough, you can go home. It's not the end. We have to review the patient and nearly after 24 hours, and if required, adjust the dosage or use combinations. Most of the patients, see, that is very common. 1/3 of the patients may require combination drug. So don't hesitate, but also don't jump into this also combination. First, you have to make like clarify. You have to make sure that this is the cause and you're trying it. And if it is not settling, you can use combination. And also one more thing, you can revert back to oral from parenteral if symptoms subside. A patient who is on continuous infusion, we give continuous infusion of metoclopramide. Okay, haloperidol also we give for vomiting. We give us if the patient is not tolerating orally, we are giving shots, but the patient is not settling. Then we can give continuous subcutaneous and continuous IV infusion. We commonly use it here. And after some days, the patient is settling. Okay, the nausea vomiting will settle by after 2 to 3 days, and you can change from parenteral to oral route. Okay, and send them back home. Only thing is you have to review the patient. They might get this again. You might have to adjust the dosage and like that. Okay, thank you. Thank you so much.
Thank you, ma'am, for the wonderful session. Anybody have any questions? Anybody?
And we'll ask questions about receptors.
Yeah. If you don't have questions, we will ask some questions.
All clear about the receptors? It's little difficult to understand. You have to go through this once. If you have doubts, you can clarify. It's little difficult portion, but at least you have to try something in your head, not like blindly writing a single drug. You have to think like that. Okay.
So what you have to keep it in mind is whenever a patient come with nausea or vomiting, have to take a proper history, identify the cause. As ma'am said, it could be uh, maybe because of medications, maybe because of electrolyte imbalance, maybe because of disease condition, maybe because of treatment. So that there are many causes. So we have to identify the cause and try to treat the underlying cause. So otherwise, we won't be able to that manage the problems fully. So if we can able to identify the cause, and if you do the proper assessment, definitely we can able to identify the cause. Okay, and the treatment also, ma'am had tell you clearly. So based on the that receptors, so which receptor is affected for that vomiting, we have to give some that kind of medications. Otherwise, that will not other medications will not help much. So that is one important message you have to keep it in mind all the time. So and review the patients. Sometimes the doctor will prescribe on medications. It's our duty, our nurse's responsibility to do the proper follow-up and review the patient, whether the medication is helpful or not. If that medication is not helpful, you have to report to the doctor and then like take some another solutions. So that's you have to keep it in mind. If you don't have any questions, we can move on to the case presentation. Ms. Pratibha Timam will be presenting a patient story today. Pratibha, over to you.
Good afternoon, everyone. My name is Pratibha Tamang, and I'm working as a staff nurse at Namchi District Hospital. Patient details. My patient is 48 years old male. Diagnosis is CA rectum. Presenting complaints: abdominal pain, not passing of stool, abdominal distension. History of illness. He had history of abdominal pain since 1 week. He also had history of not passing stool since 1 week. He had constipation and abdominal distension. He had severe abdominal pain. Examination. Patient was conscious and well oriented. Vital signs was BP 120/70 mm of Hg, pulse rate 82 beats per minute, respiration 18 beats per minute. treatment and significant investigation. Patient routine blood investigation was done. X-ray abdomen, chest X-ray, ECG was done. CT abdomen and biopsy was done. Psychosocial aspects. He is a 48 years old married man who is a laborer. He is the only member in the family to work. He has wife and one daughter. Wife is a housemaker and daughter is studying. Medications. Opioid analgesics was administered. That is injection tramadol 1 ampule with 100 ml NS IV into BD was given along with injection Ondem 4 mg IV into BD. Antibiotics was administered. Injection ceftriaxone 1 gram IV into BD. Injection metrozil 100 ml IV into TDS was given. Multivitamin injection was also given. Main concern: constipation, abdominal distension, abdominal pain, and financial problems. Summary: patient is a case of CA rectum. He was admitted with complaints of constipation and abdominal pain. All investigation was done to rule out the disease. Opioid analgesics were used to treat his pain. He was financially weak for his treatment. Discussion points. What are the problems faced by the patient? What all can be done for this patient and his family? Do we need to provide palliative care to the patient?
Thank you, Pratibha, for the presentation. I think this presentation is clear to everyone. We can move on to the discussion points. Anyway, next week we are going to learn about constipation. Now we have to think about the nausea, vomiting. If this patient that having chronic constipation, is that patient can get nausea, vomiting or not, loss of appetite. There are many problems. All problems are connected with this. This patient is having abdominal distension, stomach pain, and constipation, right? Go back to the main problem. Main. Yes. So these are the main concern of this patient: constipation, abdominal distension, abdominal pain, and financial problems. So now you tell us. So we are here to hear from you all, because we already learned about the pain management. We already learned about palliative care and communications. How can we treat this patient? From your point of view, please give some suggestions. Laxatives, very good for constipation. We can give laxatives. So before give laxatives, we have to take a proper history. What is the cause of constipation? That all things we need to take, and then you have to make a plan. Otherwise, sometimes hard stool will be there in the rectum. So that time, if you give laxatives, more pain, the patients will develop more colicky pain. So that is also important. Before prescribing medications, you have to check and take a proper history and check the rectum. You have to do the PRE and find out the things. Enema, okay, PRE examination, enema. We can see on pain management, yeah. So, Pratibha, this, how did you manage this patient abdominal pain?
Injection tramadol was given.
Okay. What was the pain score?
Pain score was 8.
8.
It was severe.
Okay. Then you gave tramadol injection.
Yes, ma'am.
Okay.
Injection tramadol was given. BD.
Okay. Did that injection is helpful or now what
It
about the
was
pain score?
after that. It was after that. It was little. It was decreased. Pain was decreased.
Okay. What do you think? That tramadol is enough for giving adequate
No,
pain relief
ma'am.
for this patient?
No, no, ma'am.
Okay.
It was not it.
Okay. So what is the next step? If the
Injection
yeah, yeah, if tramadol is not helpful, then what is the next step? Yeah, Shreya said
injection
morphine. Yeah, so if tramadol, we know tramadol is a weak opioid, that's for mild to moderate pain. So if the patient is not getting adequate pain relief with tramadol, you have to move on to the morphine. You have to stop tramadol and start morphine. So morphine is the best drug for controlling severe pain. Okay. So that one thing I need to that add here, ma'am. Do you want to add anything?
I was seeing the main concerns. All these things can next finally lead to our vomiting and nausea and vomiting. So whenever don't think of big things, think of the underlying all these small things like pain. Could be pain without resolve, as sister told, without resolving the pain, like you told, the pain didn't settle with tramadol, right? So there might be other causes also. We always have to think of even small causes like constipation. We usually miss out constipation. Nobody thinks about constipation. All these things should be addressed. Okay. Totally, we have to give a pain relief. That's all. We'll discuss more about constipation in the next class.
Yeah. So
Okay.
So, and also financial problems. If the patient is having financial problem, so again psychosocial issues. So that anxiety will be there. So if the patient is having anxiety, and the physical distress will increase. Okay, so we have to listen his problems like financial. If they have financial problems, as I mentioned last sessions, you have to find out some solution. Have to connect with this some NGOs near. If you have a palliative care NGO nearby, you have to try to connect with them so that they will try to help them. So and yeah, these kind of maybe we can find out the money for like conducting small food festival, something like that for this patient purpose. So then that money they can use for their treatment. So that kind of things you can do, and seek always seek community help. Community participation is also one of the major chunk here. So have to connect with the community that persons. So we got one more case presentation today. If we have time, uh, if you are okay with that, please present that patient also so that you can get enough idea. Birmala, Bimala Rai, are you there? Bimala, are you there?
Yes, ma'am.
Yeah, so please present your patient story. We need to discuss that patient story also. Vimala, it's over to you. Can you able to see the slides? Twinkle, please read this patient story. Twinkle, please unmute.
Can you hear me?
Yes, yes.
Thank you.
Yeah.
Okay. This particular resident is gender male and 44 years old, and he's been diagnosed with acute gastroenteritis with enteric fever and hypertension. The present complaints, he had come with fever and chills past 3 days, loss of appetite, body ache, vomiting, stomach pain, pallor, and diarrhea. The history was admitted in hospital with the symptoms of fever, stomach pain, and vomiting, and also diagnosed with age and enteric fever, fatigue, decreased daily activity, vomiting, fever with chills, pain in stomach, loss of appetite, and diarrhea. On examination, the patient was conscious and oriented. The vitals were 98 degree Fahrenheit, respiration was 22 beats per minute, BP was 130 by 90 mmHg, pulse was 68 beats per minute, saturation was 98%. On pain scale, patient is having a moderate pain, about 6. So the treatment and the investigations were, at present, patient is admitted in a government hospital in male general medical ward. All routine investigations were done, which shows random blood sugar was 138 gram per dl, urea was 30.06 mg per dl, creatinine was 1.15 mg per dl, AST 75, ALT 29, bilirubin direct 0.19, bilirubin total 0.39, albumin 3.10, HB 13.6 gram, dengue was negative, viral 1.4, and AH 1:8. Sorry, the viral was 1:4, and USG mild Heltamaloglirest, normal scan of abdomen. Psychosocial aspect, 44 years married couple living with his 2 children. He working as the assistant director at education department, and his wife also work as a teacher at government school. At present, his wife is taking care of him at hospital, so she's unable to join her duty. At present, nobody is there to take care his siblings at home. That's why he want to go home as much as possible. Patient admitted in medicine ward and is getting followed treatment. Injection ceftriaxone 2 gram IV BD. Injection metrogel 100 ml IV TID. Injection fabridol 100 mg TID. Injection pantoprazole 40 mg IV OD. Injection ondum 4 mg IV TID. Injection Overon 2 mg IV SOS. IV fluid DNS 500 ml per hour, 500 ml, or alternatively RL 500 ml IV. Tab Telmo 40 mg OD. Tab Hepclude BD. The main concern was his age, enteric fever, pain, and vomiting. The summary would be 44 years, patient, admitted in government hospital in male medical ward, diagnosed with AEG. enteric fever, and hypertension. Discussion points. Do we need to provide palliative care for this patient? What are the problems facing by this patient? What can be done for this patient and his wife?
Thank you, Twinkle, for read out the patient story. Thank you.
Thank you.
Okay. We can move on to the first question. Do you think this patient need palliative care?
You all should answer. Do we need to
Yes.
provide palliative care for this patient?
Yes, very much.
Okay, can you explain why we have to give a palliative? What is a disease? What is this disease? Is it an infection or is it a chronic illness or is it a life-threatening illness? How is it? What is the disease? What is enteric fever? Enteric fever is typhoid. It is caused by a bacteria called Salmonella typhi. And here the patient was having vomiting and all gastroenteritis, all problems. That is caused by the toxins produced by this thing, and it is an acute disease. Okay, if the patient, palliative care can support the patient, nothing like, but this patient doesn't comes directly under palliative care because we can give treatment for this patient already. This antibiotics and everything is going. We give good hydration. We give antibiotics. We give all support. Patient will improve. Okay, when the toxins we give like antidotes and like all those things and all, the disease will subside. So purely this patient doesn't comes under palliative care, but we can give supportive care if the patient, if some symptom is not resolving, if the patient is having continuous vomiting in spite of all those things, then we can this thing, but not like completely under palliative care. Okay.
Any other suggestions?
It's an infectious disease, that's why.
Okay. Patient is hypertensive or taking on drug.
Yeah, of course that
plus
we have
borderline sugar.
That's the NCD. They have to continue there. But from the patient is not having a life-threatening illness, we can't tell like that. Is it like that?
If you give a proper antibiotics, we can cure this problem. Okay. Yeah. So this patient need active management and proper treatment also. So if you give a proper treatment, definitely that disease can cure. So this is not, as ma'am said, not clearly under palliative care. We can support the patients. We can. So whenever you have see a patient like this, definitely we can able to support them, but not directly under palliative care. If the patient is cured, they can go their own business. So no need to under our care all the time. So here what we have to understand is gastritis. So if there is a gastritis there, the patients can develop vomiting. Okay, so the reasons also you have to think. It could be infections, it could be drug related. So that also we were discussed earlier, NSAIDs. So if you take NSAIDs, the most common side effect of NSAID is gastritis. So gastritis is one of the most common cause of nausea, vomiting. Here is also infection. So this leads to the patients can develop gastritis. So it's our duty to assess the patient proper clearly, and if you do a proper assessment, definitely we can able to plan and give a proper treatment. Any other suggestions? Any comments? So if you don't have any questions, we can wind up today's session. Anyway, Friday we have a session on constipation and intestinal obstruction. So that time we will discuss more about that. Okay. Thank you, Dr. Nayana, for the wonderful presentation.
Thank you all. Thank you.
Thank you, Pratibha, and thank you, Chundu, for the presentation. Thank you. See you.
Thank you, everyone. Let's see in the next session. Thank you. Bye.
Thank you, ma'am. Thank you.